Guys.
Welcome, everybody. Welcome, Jorge, Suresh, Brandon, Barbara, Cassandra, Larissa, Cliff, Hans, Jasimran, Anne-Marie, Travis, Gabrielle, Rafa, Brody, Stephanie. Glad to be with everybody this Wednesday. It's been a couple of weeks for us. So really excited to hear about an interesting patient and discuss with a couple of people. So whoever would like to volunteer and discuss the case with us, please let us know. And if somebody has prepared a case or has a case they could present, that would be great. If not, Rafael and Gabrielle, and we have some good cases we could use for sure. So mostly just looking for two discussants. And while we wait, we'll see if anybody has any good news or favorite things they learned in the last couple of days. I also just finished watching the case from Monday, and I could share some pearls from that. But actually just wanted to challenge everybody to take a minute and think about the last day or two and think of just one thing you learned that you're glad you learned. It doesn't have to be magical. It can be very straightforward or simple, but take a minute, think of it, type it in the chat, and let us all learn from you too. Oh, Rafael, that sounds familiar, but I don't think my long-standing notion has been fully reversed in my mind. So that's a really good reminder. Travis is saying, thyroid storm. What makes a storm a storm? What if it's just a really strong rain? Oh gosh, I hadn't heard of that one. Nasal perforation from leishmaniasis. Ouch. Have you ever seen a case of leishmaniasis?
I have not, no.
I have not either. Very cool. What else? Let's hear it from some of the more junior CP solvers. For the 6 people who joined in the last couple of minutes, welcome. And I just kind of prompted everybody to do a little bit of retrieval practice. Just think of one day in the last one thing in the last couple of days that you learned. It can be very basic or very esoteric, whatever you want to kind of draw from the from your brain and share with everybody. That'll both help us learn something and reinforce your own memory. And just unmute and share, or share in a chat. And in the meantime, don't forget, we're also waiting for 2 volunteers to discuss with us. We'd love to have some help. Ravi, that's a great pearl, that heparin can cause hyperkalemia. And who was it? Was it Tony Brew or maybe Avi Cooper? Somebody did a really cool tutorial on the mechanisms as well as the frequency, which is actually a lot more common than I had guessed before. Thanks for sharing that one. Totally agree with Anne-Marie. If you think thinking of a single pearl to share enhances your learning, which it totally does, then discussing a whole case is definitely, you'd get the most out of this hour. So very much encourage it. Oh, that's awesome. Cindy Cooper recently got excited about Twitter, but she's taught Steph and me since we were interns and residents. she's a nephrologist who practices mostly inpatient, like hospital medicine, right? She doesn't do any renal at all.
I don't think she does any
She's
dedicated
trained
renal
in
anymore.
renal, yeah. What did I learn on Monday?
With Dr. Walk's case?
Yeah, it was a cool case. It was a young man, previously healthy, 21 years old, and software engineer, and developed pretty acute onset over a couple of days of severe atraumatic hip pain. Actually reminded me of a similar presentation I had when I was 21. Maybe a good VMR case for the future.
Oh yeah,
you know what it is.
Yeah.
Horrible sort of range of motion limitation, and that was one of the take-home points. Is if you have a joint that just can't move, there's probably some fluid in there, and you should almost certainly get some of that fluid in order to rule out septic arthritis. And if you can do that within some reasonable period of time, and a patient isn't septic, then it's good to do that before you start antibiotics. So in this case, the patient had an arthrocentesis, and it was like 130,000 cells, mostly neutrophils, which in that range, it can be crystalline. Gout or pseudo gout can cause that degree of inflammation as well, absolutely. But in this case, the patient just wasn't, predisposed to either of those things necessarily, and was treated with empiric antibiotics as well. And unfortunately, neither the arthrocentesis, which yielded like pus, nor the orthopedic kind of surgical washout yielded any microbiologic diagnosis, but the patient did improve with empiric vancomycin and ceftriaxone, and was transitioned to levofloxacin in the absence of kind of culture data. And then one of the other important take-home points from Dr. Walk was that you should always check HIV in kind of serious infectious presentations. Screening is indicated anyway, and that gonococcal arthritis is a common cause of septic arthritis in young people, but also Mycoplasma genitalium can cause recurrent septic arthritis and is also a sexually transmitted infection. And then a couple of things I learned was, I hadn't heard of this, but there's a marker called alpha defensin, which has been used to diagnose septic arthritis of prosthetic joints, and that you can do PCRs, a lot of places now for that marker. So just something totally new that was for me. Rafael, did you know that Dr. Leila was at Baylor for like 20 years before moving to Emory?
I'm sorry.
Doc Walk was at Baylor for like 20 years before she moved to.
Oh my God, didn't know. Did you know that she's from the same school as Maria?
Oh, that's cool.
Oh, wow.
In Guatemala. Mm-hmm.
Yeah. And where we stand with discussants.
Connie was going to join us. Thank you for helping us. We have the same sentiments of excitement and an impending challenge with Gabrielle's case, but it's going to be awesome. I know we're going to learn a lot. And just waiting for one more person to hop in and think out loud with us today. As we're waiting, Connie, do you want to say hi and reintroduce yourself to everyone?
Yeah, hi everyone. I'm Kanu. I'm one of the internal medicine PGY1s currently on vacation. So that's how I got the time to join CP Solvers today. Looking forward to discuss again with Zavin and Steph and learning from Gabrielle's case as always.
Kanu, remind us where you're doing your intern year right now.
Yeah, I'm doing at UMass right now in Worcester, Massachusetts. And then I will be moving to St. Vincent Hospital, which is a nearby hospital.
Awesome. Congratulations. Thank you for spending some of your precious vacation time with us.
Okay, last call. Who wants to join Kanu? Anyone? Going once and twice. That silence is deafening, isn't it? Okay.
We'll do trio.
We'll do a trio. Gabrielle, take us away. Looking forward to hearing about the patient.
Yeah, super. So this is actually a recent case. I saw this case yesterday, and I think it was actually very, very interesting. So I wanted to share with you guys, and I'm sure you will love it. So this case has a long HPI, so I will start the first aliquot with a shift complaint that is 4 months of diarrhea and intermittent fevers.
You want us to hop in briefly, Gabrielle, with some thoughts? It sounds like, yeah. Great. Kanu, what do you think hearing the chief concern?
Yeah, this long diarrhea, I usually try to kind of classify whether it's kind of secretory diarrhea, whether it's infective diarrhea, whether it's malabsorptive diarrhea. Usually something like recurrent C. diff can have this chronic episodes of diarrhea if it's not properly treated. Something like parasitic, like immunosuppressed patients, cryptosporidium, mycospora, all those things can cause these kind of chronic diarrhea. giardiasis, usually if untreated, can cause, but I think normally it gets treated very quickly. Malabsorption, our usual culprits are like celiac disease, Whipple's disease, lactose intolerance, stuff like that. So I would really want to know if there are any triggers, if there's any recent history of any allergies, or what's the age. Usually elderly people can develop kind of like secondary lactose intolerance or acquired lactose intolerance that can usually lead to it. The other thing is with the history of intermittent fevers, I'm thinking whether it's something like indolent. I'm not sure whether it could be a cancer like lymphoma or something that could be causing it versus whether it's just like constitutional symptoms, something like tuberculosis. I've actually seen multiple cases of tuberculosis in India where they have intermittent fevers and they have kind of this alternation of diarrhea and constipation that usually leads to this variable bowel symptoms. And sometimes a chronic kind of subacute obstruction can also lead to diarrhea if it's not properly obstructing, but something that's a subacute and the stools keeps passing through and it leads to like a chronic diarrhea that can also kind of cause, and I would be worried about that. So those were some of the things that I was thinking, yeah.
Beautiful, Kanu. You gave us so much with just those few words of the case so far. And I'll just emphasize, you took us through the 4 main categories of chronic diarrhea, right? You mentioned secretory, inflammatory, asthmatic, as well as malabsorptive. But with that overlay of concurrent fevers, I think very appropriately you started diving into the inflammatory category, thinking both of chronic infections. You mentioned multiple microbiologic categories already, including bacterial, mycobacterial, as well as parasitic. And then, of course, there's inflammatory diarrheas that have fevers for non-infectious reasons, like inflammatory bowel disease. I really can't add on to the beautiful start, so maybe we'll just stop there and get more from Gabrielle. Fantastic.
Awesome, guys. She's a 14-year-old female that started 4 months with abdominal pain. The abdominal pain was diffuse, and also she presented with diarrhea without mucus or blood. So at first, she went to her primary family doctor and he prescribed some antibiotics. Azithromycin, doxycycline, but the diarrhea and the abdominal pain did not improve. 3 months prior, the patient refers intermittent fever. Some days, the patient could have 3 cycles of quantified fever, more than 38 Celsius, and some days the patient did not have fever, but recently the fever has been increasing in frequency. She also refers weight loss of approximately 10 kilograms. And palpebral edema that started 3 weeks prior presentation to the emergency department.
Did you mean palpable or palpebral?
Palpebral. Mm-hmm.
Okay.
At the emergency department, also the patient presented with dyspnea, severe dyspnea. So she was intubated and we performed a physical exam. But after the patient got recovered, we asked more HPI. The patient also refers that she has more sweating at nights, a decrease of appetite and urine, but the characteristics of the urine were all normal, meaning that the color were normal, no foamy urine, or no blood in the no visible blood in the urine. Also, so for past medical history, she was previously healthy, and for social history, she comes to a song that is in Peru in the jungle. In her house, she has dogs, cats, and chickens. She refers no TB contact and no other family of them, or no other member of her family has also this presentation of diarrhea and abdominal pain. Maybe do you want, guys, some clarification of the HPI?
What was the question, Gabrielle?
Whether we need clarification.
Oh, clarification. Anything, Kanu, that you want clarified or additional details on?
No, the only probably I think Gabrielle will discuss more about the ED course, but just wanted to know if the patient was given any antibiotics or anything in the ED as well that made the patient recover or something like that. That was my question.
Sorry?
Any ED course or anything that kind of made the patient recover, or the patient kind of recovered spontaneously, or you want to discuss that later on? That was my question.
Do you mean if the
Like,
antibiotics?
Yeah, in the ED, yeah.
So actually, the patient has been with antibiotic course, and the diarrhea and the abdominal pain did not improve at all.
Okay.
And then just one question I have, Gabrielle.
Mm-hmm.
She had this severe respiratory problem that got her intubated in the emergency room, at least briefly, it sounds like. Was there a backstory of breathing problems also, or did this happen more acutely at this emergency room visit?
Yeah, so she was having these breathing problems 1 day prior presentation. It was actually very, very acute.
Okay, thanks so much.
All right. You want me to go, or?
Please. Well, yeah. What do you think?
Yeah, I mean, this is a very course that I wasn't expecting at all, but The diarrhea without mucus or blood, doesn't sound inflammatory, but the fact that I was thinking was, since it's responding to antibiotics, azithromycin and doxycycline usually cover like atypical bacterial organisms. So if you still want to keep infection, it most likely would be like parasitic causes or fungal causes or mycobacterial causes. And then I was thinking, this low-grade intermittent fever, spiking, weight loss, can we combine all of this together into one thing, like constitutional symptoms or B symptoms kind of thing, versus whether the weight loss is a function of diarrhea? And is it more like protein losing enteropathy? And that's when I was thinking of palpebral edema, whether it's kind of like a periorbital edema and patient is losing a lot of protein that is causing, that edema worse. And I was thinking whether that protein loss could be contributing to something like ARDS or, pulmonary edema that could be causing that acute hypoxic respiratory failure that led to intubation in this patient. It's certainly interesting that this diarrhea kind of so gradually progressive led to such an acute, hypoxic respiratory failure episode. But those are my thoughts. I would still want to keep kind of inflammatory on the top and probably then malabsorptive diarrhea at this point. And I would definitely want to, in this young patient, I don't know if malignancy, is it a bowel malignancy or hematological malignancy that I should be considering versus just tuberculosis, even though Gabrielle mentioned doesn't have any TB contacts, but I'm not sure if Peru is very kind of known for TB, and even if, you can have small focus, which can reactivate if you're immunosuppressed for any reason. Those were my thoughts after reading this HPI.
Thanks so much, Kanu. Really tough to connect the chronic with the acute, right? With the abdominal symptoms that we started with this like eye swelling and the respiratory failure. What I think what would be helpful in a case like this is a problem representation. Understand? Yeah. So let's do one, and everybody participating kind of and listening and in the chat too. Would encourage everybody to try to like craft one and just type it and press enter. But Kanu, give us one. Hey, you're muted.
Yeah, sorry. Yeah, so this 14-year-old female, with no past medical history, basically has chronic diarrhea for 4 months, not resolving on initial antibiotics, with significant weight loss, with low intermittent fevers and palpebral edema, and also had an episode of acute hypoxic respiratory failure requiring intubation. That would be
awesome. I think you pulled out all the really important stuff. But in choosing what to include and what to not, like I go back to one of my first questions, which is the fact that abdominal pain and diarrhea, depending on how severe it is, may or may not actually be localizing to the gut, right? Especially in children, but really in anyone. So systemic illnesses can cause belly pain and can cause diarrhea. So one historical feature I'd be curious to clarify is just like how prominent and voluminous is the diarrhea, right? Is it just frequency, a little bit, maybe, watery here and there, or is it like diarrhea with a capital D where you're just, pooping liquid buckets, right? And if it's the latter, then yes, we would have to kind of really anchor going back to our causes of infectious, more likely than inflammatory, chronic, febrile diarrheal illnesses, and then think about how they could connect potentially to the systemic illness, right? Whether with the periorbital edema, we're like dealing with nephrotic syndrome, or whether the respiratory failure is related somehow. So one possible narrative, for example, could be echinococcosis, right? And then this might have been some kind of anaphylactic bronchospastic event that resulted in a respiratory failure. Anytime you see really acute onset respiratory failure with and that resolves quickly, you have to think about pulmonary edema, right? And that's something that can come on very rapidly and then resolve very rapidly. In an older person, I would think that could be driven by severe hypertension or something less specific, or severe tachycardia, flipping into a tachyarrhythmia briefly. But in a younger person with a good heart and good lymphatics, it's a little bit funnier, and it actually makes me worry about the heart and the heart valves specifically, right? Acute regurgitant left-sided valvular lesions, MR could precipitate pulmonary edema rapidly, and then with intubation, with that positive pressure and everything, you could clear that. And then the details around the respiratory failure too, I want to know, whether the presentation seemed to be more bronchospastic or whether the lungs were full of something, right? Was there actual crackles, pulmonary edema, where the alveoli, the airspace is filled with something? And that would kind of change the problem representation a little bit. So I think there's sort of a lot of these kind of other hypotheses and narratives that we could spend more time hashing out. And do more kind of hypothesis-driven testing, but perhaps the initial vital signs and examination, even at a screening level, quote unquote, can kind of bring us forward in the case. Whether that's noticing a rash on physical exam that could be discriminating, or seeing that the patient is very anemic with sort of signs of hemolysis that might prioritize something like malaria or Oroya fever in a patient like this. Why don't we hear the next aliquot and go from there.
Perfect. So the next aliquot will be about the physical exam. So coming with a virus, the patient was febrile at this presentation with 37 Celsius, a heart rate of 122, a blood pressure of 90/60, a respiratory rate of 28, and a saturation of oxygen of 92%. So general appearing, she had I don't know how to say that in English, but a general bad, a very illness appearance. Maybe Brody can phrase that. Or can work.
I just thought malaise. Is that the word? Yeah.
Yeah, it's she looked very ill, like a general very ill appearance, and with a very bad state of hydration. She was very dehydrated, and yeah, so she needed mechanic ventilation because the respiratory compromise was very severe, and also with the HEENT, it was very remarkable because she had a very profound and very big lymph nodes, very big cervical, also retroauricular, axillary, and inguinal lymph nodes. Actually, I think they were the biggest lymph nodes that I ever seen in my life, approximately 4 to 3 centimeters. The lymph nodes were not my tenderness to palpation. And they were mobile. So for in that cardiovascular exam, it was normal, regular rhythm. She was tachycardic. For the pulmonary exam, crackles and trepitus bilaterally. The abdomen exam, she had a very distension of the abdomen and a positive acidic wave, as a positive sign, wave sign. And for the neuro exam was normal. And in the scheme, we noticed two papular lesions in the mandibular region that were umbilicated in the center, that has a central umbilication. So as this case is actually very new, I don't have very much information at the labs and imaging, but after this aliquot, I could give you some labs and the imaging that we got first, and then I will give you the final diagnosis.
Wow, Gabrielle, thanks so much. Kanu, we've got a little more to work with, adding many more layers to the case. What are you thinking?
Yeah, just one question for Gabrielle. So the saturation you said of 92%, was it before intubation or was it after intubation?
Yeah, it was before intubation.
Okay, so the intubation was mostly for airway protection, I'm assuming, rather than the hypoxia. Would that be right to assume?
Mm-hmm.
Okay. So yeah, I mean, the patient is, first of all, hemodynamically unstable, currently not febrile, but tachycardic, hypotensive, so much so that she required intubation. Gabrielle mentioned that the patient is dehydrated, and has kind of generalized anasarca. There's ascites, there's palpebral edema that we initially saw, and in the setting of these big lymph nodes throughout in the cervical, axillary, and inguinal, I usually think more of there are 3-4 things that I usually think about. One is the malignancy itself, whether it's a lymphoma. Usually Hodgkin's more than non-Hodgkin's cause these cervical, axillary, inguinal lymph nodes. The other would be something like Kikuchi's disease or acute HIV infection that usually leads to it. I'm not sure if tuberculosis usually leads to all these lymph nodes together, which I was initially thinking. So I would rather keep that low on my list. And thinking about the crackles bilaterally in the lungs, I'm thinking it's more pulmonary edema. So I think this is heading more towards kind of a protein losing enteropathy for me, which is causing all this, symptoms. I'm still not sure why this is leading to such a sick picture, whether there's an infection on top of it, just because the patient is immunosuppressed. I would definitely like to get kind of HIV white count just to make sure what's the status. And regarding the skin exam, so the 2 papular lesions in the mandibular area with central implication, usually it just clicks for me as molluscum. It's not usually common, but it could be unrelated in a case, but it could also signify as that the patient is immunosuppressed or immunocompromised, and that may be caused, that may have led to like such easy molluscum infections. Maybe that's a clue that I'm thinking about. So those are my thoughts with the exam. So tying it all together, I'm still thinking this is more inflammatory versus neoplastic at this point, such diffuse lymph node enlargement. And I would consider that in my problem representation, diffuse lymph node enlargement and anasarca.
Yeah, Kanu, great thinking through this. With this added layer, as you mentioned, updating your problem representation of chronic inflammatory symptoms, chronic diarrhea, and now a pretty profound, much more acute respiratory failure and diffuse lymphadenopathy that we're hearing. So multisystem disease, as Zavan was mentioning before, just that teaching point of GI symptoms not necessarily meaning the problem is only in the gut, I think really becomes a relevant theme for this case here. I think for this young girl, the infectious differential diagnosis and categories really are more prominent. I think it's very important to have on the background once we've worked through our infectious categories, inflammatory but non-infectious syndromes, as you mentioned, lymphomas, right? An autoimmune disease like lupus, absolutely. But with just sort of the degree of her fevers, as well as potentially some, right, risk factors for acquiring infection with her living situation, I think maybe we can sort of tag team together, sort of thinking through the infectious categories might be the first way to go about doing this. So maybe we can sort of group think on this here. Can you guys think of any bacterial processes? And of course, we're thinking of standard bacteria, but we also, I think, need to think of kind of zoonotic infections that fit in the bacterial category that could cause this chronic diarrhea, inflammation, lymphadenopathy, respiratory failure. And really what we're going to do, as people have heard us do before with our infections, kind of work through bacterial, viral, mycobacterial, fungi, and parasitic.
I think, I mean, some of the zoonotic bacteria, sort of Brucella, for example, that is probably to some extent endemic in that part of the world. This wouldn't be the typical presentation. More typical would be a little bit more, you know, kind of joint pains, certainly the fever, night sweats, and I don't know about this kind of fulminant and initially presenting mostly with GI symptoms. Some Bartonelloses can probably do something like this, but nothing's kind of, I think this isn't like a classic tularemic presentation. I don't know. I think it's less likely. Yeah.
Viral categories, you know, I think you just made a good point, Kanu. I think we just need to think about what's her immune status, first of all, and an HIV test is going to be a big decision point here and affect all of our infectious differential diagnosis here. This would be a pretty profound presentation of, and a bit chronic for some of the mononucleosis type syndromes, which can, right, present lymphadenopathy, pretty severe systemic illness. I'm talking about things like CMV, EBV, but to me, just the time course here isn't fitting well with that. Whether she's HIV positive or not is sort of, to me, the big decision maker in the viral category.
Although if the patient's HIV positive, HHV, is it 6 or 8 related, like Castleman's sort of systemic inflammatory type syndrome certainly could look exactly like this.
Yeah. Mycobacterial, Kanu, you mentioned tuberculosis. Yeah, I think really is very important to consider given the multiple organ systems involved here. Right now, we don't think she's at risk for non-tuberculous bacterial disease as much, but something to explore later on. And then that brings it to fungal disease. Kanu, you nicely overlaid just thinking about what's the significance of these kind of umbulated papules you had. Molluscum, particularly in a child, right, would be a common thing to have, although it certainly doesn't explain everything. And then cryptococcosis is an important consideration that can cause umbilicated belly button-like papules with lung involvement, with gut involvement. So I think that'll be a really important category. And then other disseminated kind of endemic mycotic infections as well that she would be at risk for in this area. I don't know if paracoccidiomycosis is a consideration. Oops, sorry, Siri. But I think thinking.
Oh, is it paracoccidio? And it sounded like Siri.
So Siri activated. And then that finally brings us to sort of parasitic category. What thoughts do you guys have there in terms of what she's at risk for to explain these layers of symptoms?
Usually I know ascariasis can cause diarrhea with lung involvement, but I've never heard of lymphadenopathy with ascariasis or something like that, but that was my initial thought. A couple of liver flukes can cause protein losing enteropathy with their infections, but again, this lymphadenopathy, I'm not sure. We can certainly think that immunosuppressed status, on top of it, there's a parasitic infection that could explain, but trying to tie it all together, I'm not really sure I can think of a parasite otherwise.
Totally, I think you nailed it. Like, I think everything could be sort of a parasitosis with subsequent systemic kind of dissemination, except the lymph nodes. I wouldn't know how to tie into any of the sort of enteric helminthic infections either.
The only last thought I want to add before we get more data is just how profound her respiratory failure is. I'm thinking of sort of three categories. The category you mentioned, Kanu, of just kind of third spacing and non-cardiogenic pulmonary edema from the severity of her illness. Is there primary lung infection with whatever is going on? And we mentioned particularly, for example, that some of the fungal conditions definitely could have a predilection for the lungs like that. And then I don't know in the background if she has been at risk otherwise for cardiomyopathy and elevated pressures. Chagas disease, I really can't speak at all in a 14-year-old girl, sort of what the manifestations and presentation, but certainly a parasitic infection that can affect both the heart function as well as the gut function. But perhaps we can learn more from more expert people in the audience, kind of her age and the time course here. I think it really doesn't fit for some of those kind of dilatory pathophysiologic states. But just the severe respiratory illness, I was very surprised to hear once hearing the initial story. And I'm thinking about it in those three categories of reasons why she has needed to be intubated for this.
Did she need to be intubated for this? In fact, I'm not convinced that we can, there's too much wrong with the lungs. Okay, so what if, okay, she has edema in her eyes, right? She has edema in her peritoneal cavity. Her albumin might be 0.9 for all we know. So yeah, sure, she has some pulmonary edema that's causing her to be a little crackly and it's causing her to have a slightly diminished room air O2 sat. But I would guess that her bicarb is also like 10 right now, right? So what if the tachypnea, right, and that respiratory quote unquote distress, which is really just like, could just be, a very increased minute ventilation, is just compensatory and her lungs are 92% fine, right? And I think there's an important teaching point there that you don't want to intubate people who are just hyperventilating, compensating for metabolic acidosis, especially for a young, healthy set of lungs, set of diaphragm and chest wall musculature. It's hard to do better than the body. And I think even if you, like, once the tube is in, and you have them on a machine and you sedate them and there's no respiratory dysynchrony, fine. Okay, maybe you can do just as well blowing off the COPD, but two major questions. Why? And two, in the process of intubation, even those several seconds of you having given the patient a paralytic, some sucks, whatever, to intubate them, suddenly their bicarb is still 8, right? And you're actually not potentially ventilating. And their pH can very transiently dip into the 6s, right, and cause them to code. So I think it's really important to try to differentiate, and an X-ray is a really quick, right, method. Like if the X-ray looks mostly clear and the patient is like looking like this, and there's no actual signs that there may be like sudden airway compromise, collapse, obstruction, something like that, I think it may be prudent in some cases to just sort of like take a few deep breaths yourself, and question whether this is really respiratory failure.
It sounds like she got extubated pretty quickly from the additional story that Gabrielle got. So that's a great point. Gabrielle, why don't we get more info from you?
Yeah, great thoughts, guys. So I forgot to mention that when the patient presented, she had altered mental status, confusion, but after she recovered, the mechanical ventilation was discontinued. So for the labs, I have she had an hemoglobin of 8.9, platelet count of 120, white blood cells of 3.9 with a normal percentage of differential, no eosinophilia, and the sodium was 133, potassium 3.2. Phosphor normal, chloride normal. There were some mild elevation of the liver enzyme, but not so severe. The albumin was quite low. Let me check if I have it on my notes, but it was less than 2. It was pretty low. I don't have the exact number, sorry. The bilirubin was normal. So at this point, as some guys in the chat, we wanted also to know what was the HIV status, and the ELISA for generation of HIV was negative. Also, we wanted to know the HTLV1 serology, because there were some previous studies that show that HTLV1 co-infection with the strongyloides could be more severe and predisposed to a systemic illness, but the HTLV1 was also negative. The blood cultures are still pending. The urine cultures are still pending, but the sedimental exam of the urine showed no abnormalities. Also, the microscopic examination of the stools showed no abnormalities for the CL Nielsen, to see if there were some coccidias. No strongyloides in the microscopic examination, although this is a not very sensitive test. We didn't see any abnormalities. And talking about the chest X-ray, it showed an interstitial pattern, possibly related to the pulmonary edema because of the profound hypoalbuminemia, and also a reticular, but it was kind of surprising that because we also noticed a reticulonodular bilateral pattern. We also sent some sputum culture, some sputum samples for doing a CL Nielsen for thinking for TB, also for doing gene expert of TB, and for doing the culture in Lowenstein-Jensen. But for now, the gene expert is negative for TB. The next aliquot will reveal the final diagnosis.
Kanu, any comments on any of these labs, or any guesses as to what that next aliquot is going to be?
Yeah, I mean, the first thing that always look at the CBC is not just look at one, but all three, and here all three are decreased. So that's kind of worrisome for me, the pancytopenia, even though the white count is just slightly decreased, but I think we should consider that. So hemoglobin 8.9, platelet 120, white count 3.9. I mean, it's not super sick, but again, I think warranting further testing like folate, B12, just look at the reversible causes, TSH. But again, like hemoglobin 8.9, I usually want to consider emergency causes for anemia, like hemolytic anemia or TTP, something like that, first of all, with such a sick patient. So I always look for the retic count to see if marrow is responsive or unresponsive, and that kind of warrants my further testing. Platelet count of 120, she's not bleeding or anything from anywhere, but again, it's decreased. I want to look at the smear. I think the peripheral smear tells a lot about whether, how the white cells are, how the red cells are, if they have any particular abnormalities or anything. But again, all this could also be explained by malabsorption for the vitamins B9, B12. You want to keep it simple. But it could be as dangerous as like, aplastic anemia or something like that, which could be predisposing to infections or something like. Chemistry wise, again, the lights are kind of low, especially sodium and potassium, so that can be explained by the diarrhea. Again, I was actually expecting that, Gabrielle, does the patient have any acidosis, like the CO2 low or anything?
So I don't have the exact numbers, but I don't have the exams before she was intubated, but after she was intubated, she recovered. Yeah, not a very profound metabolic acidosis or respiratory alkalosis.
And renal function was fine as well.
Yeah, renal function, although she was severely dehydrated, renal function was fine.
And Kanu, just by the way, like, as you're looking through all these labs, like, there are two important questions, right? One is no matter what started all of this, there can be certain complications that can be life-threatening.
Yeah.
Right? Yeah, she's had diarrhea for 4 months and her potassium is now 1.7. That needs immediate attention, right?
Yeah.
And then the other concurrent question is there a clue to the primary diagnosis? And I think in these basic labs, there's neither of those.
Yeah.
Right? Like there's neither something in the labs that's gonna like hurt this girl right now, nor is there anything like super discriminating. So if you had to guess like where the diagnosis is gonna be, like what is the feature of the whole case altogether that seems to most kind of stand out right now that you would kind of want to like follow and that might be the clue to the diagnosis? And I might be asking a bit of a read my mind question, but
yeah. I think the pancytopenia and the hypalbuminemia, I think those are the two key things that I'm looking for. The hypalbuminemia is kind of making me think it's something, obviously the patient is using the protein, and the pancytopenia, with the picture of diffuse lymphadenopathy is something that I really should consider.
Yeah. Exactly. And I think that the lymphadenopathy is definitely like one of the easiest places to go if our non-invasive tests so far have been unrevealing. Now, thus far, like, disseminated TB isn't a diagnosis you make overnight a lot of, right? Like, and by the way, she may not have pulmonary TB. And that's why the gene expert on the sputum presumably was negative. But her lung pathology might just be the pulmonary edema from the hypoalbuminemia, blah, 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 right? So this may still be some infectious cause of pancytopenia, lymphadenopathy, fevers, GI involvement, etc. But this could very much also be a lymphoma with just systemic, severe systemic inflammation and the association with nephrotic syndrome, although we're not necessarily seeing that on the urine sediment. So just in the interest of time, Gabrielle, why don't you tell us the diagnosis, and maybe we can have a minute of reflection and I hear some teaching points from you.
Sure. So as you said, the first consultation that this patient had was actually in the hematology department because they were thinking about lymphoma because of the profound lymphadenopathy and also the chronic diarrhea and the fevers. So they decided to do a pathology of the lymph nodes, as also Kushal said in the chat. But surprisingly, the lymph nodes showed calcifications, fibrosis, and granulomas, well-formed granulomas, and also, very surprisingly, some yeast compatible with Paracoccidioides brasiliensis. So the final diagnosis was a disseminated paracoccical disease. So for doing addition points, because this disease can have a lot of manifestations actually, paracocci has basically two types of presentation, or we can say three types, the asymptomatic, the juvenile form, and the chronic form. And the juvenile form that is presented in infants and the pediatric population, adolescents, have this disseminated disease with systemic symptoms. It can affect, it can have pulmonary disease, also the chronic diarrhea, the fevers, the anemia, the lymphadenopathy, and also one clue in the physical exam was the central umbilicated lesions. And one take-home message could be that not only molluscum contagiosum can cause this, but basically lots of disseminated fungi infections. And for the chronic phase, this is actually the most common presentation, and it presents in adults. It usually manifests with pulmonary manifestations and ulcers in the mouth. And the ulcers in the mouth are very painful and produce instability of the teeth. Yeah, and also some differentials that we were thinking about, because this chronic diarrhea and chronic fever, we're thinking about TB, because Peru is very endemic for tuberculosis, and tuberculosis can have very broad manifestations. Also, another differential was brucellosis because of the weight loss, the sweatings, the diarrhea, and another differential was also strongyloides, because Peru is also endemic for strongyloides, and also she comes to endemic zone. But yeah, I wanted to share this case because it was actually very surprising, because I was thinking in lymphoma, but and the lymph nodes were the clue. A rapid example, it say that basically give that diagnosis.
Gabrielle, just to clarify, you said disseminated paracoccygeal infection, right? Did you say that? Okay, thanks.
Yeah.
Thanks.
Amazing case, Gabrielle. And Kanu, thank you so much for discussing with us, and you did an amazing job. I think from the beginning to the end, from that first chief complaint all the way to when we ended up in this like super complicated case. It was a pleasure to learn with you, and I learned a lot. I've never seen a case of paracoxy either until today. So always a privilege to learn with all of you here.
Yeah, I'm privileged to learn from you and Gabrielle. In the end, I was thinking it could be a fungal infection, but I was just not sure. But yeah, again, amazing case. It's so humbling to discuss these cases in the VMR, and that's why I like to join.
And Brody, I want to thank you for doing the teaching points
It's Gabrielle himself. Yeah,
oh my God, Gabrielle, how are you doing that? That's amazing. Brody
Yeah,
was
you did
surviving.
it.
Thank you for that too. But okay, and as we just wind down the hour in the last minute, I'll ask for some retrieval practice again. Everybody, take a few seconds to think what was your favorite take-home point from the hour, and type it in the chat, and we'll just see everybody's responses and sign off. I'm assuming people are slow typers. Oh, Kanu, that's actually a really good exercise. Redoing the problem representation in retrospect. Awesome.
Oh yeah, is there anybody who knows? I don't know if there's any relation between umbilical lesions and paracoccydomycosis. I know Travis put it there, but I don't know if there's any relation, whether it was a molluscum or that can paracoccydia cause it.
You know, Gabrielle?
I think that's what Gabrielle said.
Yeah, sure. Yeah, paracoxy can cause these umbilicated, central umbilicated skin lesions. And also some differentials are histo, molluscum contagioso, actually lots of systemic fungi infections.
Cryptococcus is the most classic one.
Yeah, crypto.
Yeah, histo most of the time I think doesn't cause as much like skin disease. Blastomycosis is also common, but those skin lesions are a little bit different.
That's right.
Not as much like papules, but more like warty looking things.
Yeah.
Okay.
All right. Thank you.
Thank you, Jasimran, for that last couple, and Kushal. And everybody have a great day. Thank you again to everybody who participated.
Great to see you guys. Thanks, everyone. Bye.
Have a good day.